Good morning. I would like to take this opportunity to thank the board members at Yakima Valley Regional Hospital for allowing me to present a project that I endorse involving improving patient care through a palliative care program in the Yakima Valley community. I have been a nurse for 10 years. I have worked in the ICU for 8 years. Also, I'm sure you know have served as the director of the intensive care unit here and the interim director of the ED. So then we all know that the mission statement of the Yakima Regional is to improve the health status of the communities we serve through compassionate, high quality, accessible, and cost effective care. And this is done through a partnership, dedication, service, quality, and stewardship. Did you know in the hospital, or in the United States, 53% of all deaths occur in the hospital? A study in 2004 of 252 hospital deaths concluded that patients who died in the ICU did not have informed discussions of end of life or palliative care as an alternative treatment option before admission. Um, and the quality of end of life care was disrupted for these patients with fatal pre existing chronic diseases who were admitted to the ICU before death. Lack of clinical experience, knowledge, competency with the end of life care influenced the admission of the patients to the ICU regardless of their poor prognosis. Decisions regarding the pursuit of aggressive therapy versus palliative care must be addressed with patients by physicians who are competent in the end of life care, as this will have a profound impact on both the quality of care and the effective use of limited hospital resources. Um, there was a controlled study done, it was a 2 year study of 5 teaching hospitals, and it was published in JAMA in 1996. It involved over 9,000 patients. The study found that only 40% of physicians knew their patients preferred to avoid CPR. And then 46% of DNR orders were written within 2 days before their death. Another interesting finding of the study was that 50% of conscious patients who died in the hospital, their family members reported them having moderate to severe pain in at least half of their stay there. So, how can we improve the quality of care? We can implement a palliative care program at Yakima Valley Regional Hospital. So we're going to discuss today just a little bit of little definitions, program design, outcomes of the program, and how we're going to measure the successes, resources that we're going to use, and how we can even take it a little further, and then of course the cost involved. So the definition of palliative care. Palliative care, it means patient and family-centered care that optimizes the quality of life by anticipating, preventing, and treating suffering. And just so we know, the difference between hospice versus non-hospice palliative care. Hospice palliative care provides palliative care for those in the last weeks or months of a patient's life under federal Medicare benefits. Non-hospice palliative care is appropriate at any point in a serious illness. It can be provided at the same time as life-prolonging treatment, and palliative care does not require enrollment or benefit choice. So, a palliative care program. As of 2009, 60% of all U.S. hospitals reported having a palliative care program, and 80% of hospitals with more than 300 beds reported having a program, a palliative care program. And this is how the rest of the United States is moving. And you can see here on this slide how it's a growing trend of hospital palliative care teams in the United States. So, what does a palliative care program look like? The initial team consists of one physician, an MD. This could be a hospital resident or an advanced practice nurse, one nurse, a social worker, and a chaplain. And then, as the program develops, we can add other disciplines such as physical therapy, pharmacy, administration, data collection, quality assurance personnel, and psychology, and other roles in the hospital. So, the palliative care program, the goal of this team is to provide a consultation service for physicians. We want to improve patient family physician communication and decision making, provide pain control and symptom management, and addressing our patients' spiritual needs and emotional suffering, and then, of course, assuring a safe discharge plan for these complex patients. So, how do we ensure a successful program? Well, we designate a program director to integrate this program into the mission and goals at Yakima Regional. And then, of course, we ensure the financial considerations for the data collection and the outcome management. And costs of the program would include stuff like staff education, team development, and then, of course, salaries. So the outcomes of the palliative care program, that of course the outcome is to decrease the cost per inpatient case of care at Yakima Regional. An outcome is to have no gap by race or ethnicity. We want to increase the patient satisfaction scores via the HCAHPS. We want to decrease the 30-day readmission rate. And then we want to use 100% of evidence-based practice. That's what our country is moving towards, and we want to ensure that our patients are receiving evidence-based practice care. We want to decrease their time in the ICU, and then, of course, we want to lower hospital mortality rates. So how do we measure the success of a palliative care program? In an effort to provide evidence of a successful program, we're going to measure, of course, operational metrics, which includes like number of consults, referring physicians, and the disposition of the patient. And we'll measure clinical metrics, which are items like improvement in pain. We want to measure satisfaction via the physicians, family members, even the staff. And then we want to measure, of course, the financial metrics, cost avoidance, billing revenue, and then length of stay. So the resources that we're going to use for this program, the National Quality Forum has developed a framework for preferred practices for palliative and hospice care. And this includes 38 preferred practice recommendations for programs that are initially starting up and then to maintain the programs. And of course, this framework is guided by the Center for Advanced Palliative Care. You can use this program as a template for new programs. So in the future, what would this look like? Well, we will start off probably in a 9 to 5 or a daytime hours kind of situation, but we want to increase that to a 24/7 coverage. We also would love to receive accreditation from the Joint Commission for Palliative Care. We want to provide outpatient services and then provide services to the community. So the financials part. So our goal here is to reduce cost to about $2,600 per case. And then we want to increase our revenue by submitting professional billing receipts. And there's a study done by Morrison. It was called Cost Savings Associated with U.S. Hospital Palliative Care Consult Programs. And I'll show you on this slide, you can see how Morrison studied hospital data from 8 hospitals with palliative care programs over 2 years. The patients receiving usual care, which is the dot, had more direct cost per day than those compared with patients that received palliative care consultations in days 7, 10, and 15, respectively. So in summary, using the resources that were provided by the Center for Advanced Palliative Care, we can begin a palliative care program. And as healthcare reimburses are bundled and patients' resources can be allocated and identified by a team and then dispersed. And we want to, of course, improve the end-of-life care for the community of Yakima Valley. Thank you.